she will give us a presentation about urinary or fecal incontinence treatment.
Good morning to all. My name is Kristofic. First of all, I would like to thank the organizers for the ability to speak with you this morning. It's my privilege as a practitioner gynecologist. I work at the University Hospital Center in Rijeka, which is one of the, because everybody's showing the institution they work in. So we are the tertiary center in Croatia. We are one of the 4 major hospitals in Croatia, and this is a picture of our new building that we hopefully will enter within next 6 months. As a practitioner gynecologist, I deal with the operations every day. So for the past 10 years, I'm the head of the Department of General Gynecology and Urogynecology. And if you think why somebody who is practicing surgery is talking about the conservative treatment of the urinary incontinence, colleague Lukanovic, before in his talk spoke about the different types of operation that we use to treat the urinary incontinence in females. I can talk about the females because I'm a gynecologist, so I don't deal with the male patients. We have numerous types of surgeries. I would say more than 100. And when you have such a vast number of operations, that only means that there isn't a single one which is effective for every patient. So when you have a lot of operations or a lot of procedure for something, you should know that there isn't one common which is acceptable to all the patients. But urogynecology is a field of surgery where we have to tailor our procedures to each patient, because it's not the same if you have a patient who has a stress incontinence and she's 35 and works a heavy job. For example, she works at the kitchen or she's a nurse, or you have somebody who has a sedentary work, so somebody who is sitting all the time, or if you have a patient with BMI 25, or you have a patient with a BMI of 45. So we have to tailor our treatment to every single patient. We have all in our lives different life goals, but one of the first life goals in our lives that we all celebrate is when our children get their as we move through the life, our, let's say, life goals change. In the autumn of our years, we all have the common goal again to be living without the diapers. Unfortunately for some people, female and male, it's not in their golden years, so in their 70s and 80s. Some patients have a problem with urinary and even fecal incontinence in their 20s, 30s, and 40s. So there are persons who are active, who work, who have families, and who need to have a quality of life, and they don't have it. And it's our job, and it's our mission to give them a better quality of life. So this is like a sketch slide, but it tells you a lot about the quality of life of each and every one of them. So David talked about the different types of urinary incontinence, and for you, I don't think it's very important to know all the details, but there are 3 main types, and as you can see on the slide, some of those types of urinary incontinence interfere with each other. So we have to sometimes have different kind of diagnostic procedures to determine the exact type of urinary incontinence in some patients, because seldomly they are just strict stress urinary incontinence. Seldomly they are urgent urinary incontinence, and in a lot of patients it's some kind of mixed situation. As a definition, I won't bother you with the International Continence Society definition. David talked about some of the definitions. What I would want to emphasize is one part in the end, it's called nicturia. When we talk about the problems our patients have, we usually ask them, how often do you void? How often do you go to the toilet? And the patient who had urgent urinary incontinence or mixed urinary incontinence normally void during the day 15 or more times. But also, the majority of those patients have a night void. It's called nicturia or nocturia. Some of those patients wake up during the night 5, 6, or more times a night. And you can imagine the quality of life. It's normal when you have a little baby and you're breastfeeding But it's not normal when you're 40 to be waking up 8 times a night to go to the bathroom. What is very important when you are talking to the patient is to determine the fact, is the patient waking up during the night because he has a shoulder pain or he has a loud neighbor who woke him up, and then when he's awake, he goes to the toilet, or is it the situation that he is waking up from sleep just to go to the toilet? Majority of our patients don't have a problem with the fact that their surrounding is loud, so they need to go to the toilet. The need to urinate wakes them up from the firm sleep. And you have people who work and get up during the night 5, 6 times during the night, and you can imagine how is their working day afterwards. It's so tiresome, and it's not something that lasts a week, a month. It lasts for years. David talked about something about the incidence of urinary incontinence. So we have a vast range from 2 to 55%. When you're talking about what the people are saying all around the world, yes, but people are still reluctant to speak about the urinary incontinence. As Juan yesterday said, it's still a taboo thing, and all the incidences that we can are based in the literature are from all the kinds of questionnaires and about the patients who came to the medical doctors or healthcare providers to seek for the help. So the incidence is from 2 to 50% or even more, depending on the sex, female or male. So we know that the ladies have more problems with urinary incontinence than men, but it's not just a ladies' problem, it's a universal problem. And for the persons that are in healthcare facilities for the elderly, the incidence is much more higher than 15%. So yesterday you spoke about the fact that this is still the taboo thing. So I put some few slides inside. I know that you are not the doctors. This is from the talk I had with a gynecologist in one international meeting, which is I had a speech about how to communicate with the patients with urinary incontinence. And it's very important because we as a doctor still sometimes don't properly communicate with the patients with such conditions, with urinary and fecal incontinence. So most healthcare providers, firstly, do not routinely ask their patients about incontinence. And sometimes in some surroundings, patients do wait for their healthcare providers to ask them a question. And if you don't ask, they won't tell. So it's a closed situation. Then what is called in the literature is the doorknob moment. So the patients often are embarrassed to discuss this, and they think that there are no available treatment options. And sometimes even they speak to their healthcare providers, and they say, the urine is leaking, and the ladies can hear the answer, well, you gave birth to, doesn't matter, 1, 2, 3 babies, it's normal. No, it's not normal, and it's still the answer that some of the ladies hear from their general practitioners, gynecologists, urologists. And we have to deal with this because it's not true and it can be dealt. And such a patients wait to mention their concern until they're leaving the office. And this is why it's called the doorknob moment. And what is very interesting to know and important to know that while it may appear to be their afterthought, this problem bothers them a lot, but they're embarrassed to share that information with their healthcare providers. So majority of our patients are suffering, let's say, in silence for many years because they are embarrassed to discuss the problem. I worked in Europe, and if this problem is in Europe, you can imagine what kind of problem is all around the world. So if we have a problem like this in a European country as Slovenia, Croatia, I can just imagine the problem world around. So it is estimated that around 50 to 70% of ladies with urinary incontinence do not seek medical help and treatment. So you have the references below. It's not my opinion. The average duration of the urinary incontinence symptoms is around 6.5 years before seeking help. This is because the urinary incontinence routinely doesn't start as a major leakage of the urine. Urinary incontinence usually starts with a few drops of urine and it aggravates by time. So the patient at that time revolves the compensatory mechanism. So they start wearing pads. First, menstrual pads. Afterwards, they start using specialized pads for urinary incontinence. And my hair gets up when I see the commercials for the urinary or hygienic products for urinary incontinence, because it is not normal for the ladies or anybody to wear diapers 24/7, 365 years, 365 days in a year. It's normal for the babies, but we protect the baby's skin by putting the ointment on their skin. And the people with urinary incontinence do not put the ointment and the creams on their perineum, and they get such a nasty inflammation of the skin. We have a colleague, she's a dermatologist, and she can tell you what the urine does to the skin, because it's a liquid which is very strong. So those people adapt the way they dress. They wear white clothes, darker clothes. Why? Because they're afraid that the urine that will leak will be visible to others. So during the summer days, in Croatia, which is Mediterranean country, you can see them wearing dark colors, which is crazy. They adapt their behavior, they drink less water or less liquid, because they know if they drink, they will have to go to the toilet more often. So if I asked you before, what do you think about the incidence of the urinary incontinence in the women who never gave birth, and they are in the age group between 16 and 30? I don't think anybody of you would say that it's 13%. That's more than 1 in 10. So it's not population of 40 years old ladies, 50, 60. It's young women from 16 to 30 who never had birth. So David told you about the dogma that cesarean section prevents problems with the urinary incontinence and pelvic floor disturbance. It's not true. So we have young patients who have a problem. My youngest patient that had a functional magnetic stimulation in my hospital, she was 14 years old girl who trained athletics, high jumps, and she had urinary incontinence. Healthy, sporty little girl, but we know that some sports, if are done in the years of growth, can lead to problems with urinary incontinence. That is volleyball, because you have with the smatches higher intra-abdominal pressure than normally. Lifting of the weights, but lifting of the weights is not such a widespread sport, but some of the athletics, especially high jumps and volleyballs, are. So some athletic sport activities can, if not done properly and not trained properly, lead to this kind of problem. So this 14-year girl was referred to me by a specialist pediatrician who knew, because we work at the same hospital center, about the functional magnetic stimulation, and this girl is great. She comes once a year to the therapy, and she's quite nice. So even girls she's in elementary school can have problems. So you cannot operate to the 14-year-old girl, and she cannot go to the school and leak urine, because for some other minor problems in her life, nowadays children get bullied on the social media in school. You can imagine her life in her school. So we had a different diagnostic procedure. David told you about the history taking. So we don't need a fancy instrument. We don't need a fancy practice. Sometimes it's very important just to speak with the patient and to ask appropriate questions. Yesterday we spoke about the questionnaire. We have a few great questionnaires. One of them is ICIQ. I was fortunate enough to validate the one for a Croatian language, and we made it with a local pharmaceutical company, or regional pharmaceutical company, and it printed it out as a handout, and it's dealt to the general practitioner offices, urological offices, and gynecological offices. You can find it online. So in every of your countries, ICIQ questionnaires can be found. It's 5 questions, and the ladies can either do it online, or they can write it down in the comfort of their home, and they can come back. The idea that this information could be placed in the waiting rooms is for me great, because in that way they don't have to make, the patients don't have to make the first step and to reveal it to their healthcare providers, but it can be done in, let's say, a softer way. So the voiding diary is another aid. It's a piece of paper where you, during the course of 3 days, you write what kind of liquid are you drinking, why is it important? Because I had a patient, female patient, who told to me that she is frequently voiding. So she had something like 15 voids during the waking hours. And when she came back to me with her voiding diary, the liquid, majority of the liquid that lady drank was beer. So yeah, the beer is kind of diuretic. So we all should know that soft drinks like colas, Fantas, things like that, they promote voiding. Coffee drinks, teas. So when we are talking about our patients, we should tell them, please drink water. Still or sparkling, but naturally sparkling waters are fine. But wine, coffee, and drinks like that should be avoided because they promote avoiding. So they just write it down during the 3 days, and they write down to which activity they have in urinary incontinence, so you can know what type of incontinence she has. And at the end, the examination by the gynecologist or urologist. In different countries with urinary incontinence, different speciality of doctors is dealing. So in some countries, gynecologists deal only with the female patients, in some countries, urologists, because not every country in the world has subspecialization of urogynecology, so this is the combined field. So you should know in your country who is dealing with urologist, gynecologist, it doesn't matter, we all do the same job. So this is just the formality. David showed you like a flow chart which is very detailed. I made one which is more memorable and simplified. So first we have to determine the type. There are 3 major types. So when we know, we go to the therapeutic options. Always we have to talk about the patient to the change of the lifestyle. And that is drink less coffee, drink less alcohol. You know all that you cannot change somebody for 40, 50. You can apply to them to drink maybe 3 coffees and not 6, but they will still drink coffee. They will still drink alcohol because you cannot change the way the person acts. What the next step is, and we all, not just the next, but at the first time you tell them, please do pelvic floor exercises. As I'm a gynecologist, on every gynecological examination, I test the strength of the pelvic floor muscles because as a gynecologist, it's easy for me. And we also have a little instrument that can quantify the strength of the pelvic floor contraction. And you would be amazed how a little number of ladies can contract the proper muscles. So when you ask them to contract pelvic floor muscles, usually they contract abdominal wall muscles, inner thigh muscle, or gluteal muscles. So they think it's when they contract the gluteals that it's pelvic floor. No, it's not. Because when you properly are doing pelvic floor exercises, you almost don't see the movement on the other outside part of your body. So we have to teach our patients how to properly train. And when you have somebody with a weakened pelvic floor, they cannot isolate those muscles. And the great thing about the functional magnetic stimulation is that after around 4 to 6 sessions on the chair, the patient get the sense of those muscles because they are strengthening already, and they can work out pelvic floor muscles at home better and more quality. So we get them the handouts how to work the pelvic floor muscles, and we have the same explanation online, so they can see the physiotherapist who is showing on that video how to work out the pelvic floor exercises. For some patients, we teach them about urinary bladder exercises. That is to void in a certain time limit. So not to go void every 30 minutes, but to start expanding the time between the two wards. And there are techniques how to teach the patient to do that. Something is very important with the ladies. Majority of the ladies have aggravation of their problem in the premenopausal years and in postmenopausal years. Still, even now, a lot of gynecologists are reluctant to prescribe to the patient estrogen therapy. It doesn't have to be estrogen therapy by mouth, so systematic. I always prescribe local estrogen therapy. It can be either cream, which I prefer, or the tablets or vaginalates, those are pills that are dissolved in the vagina. Why I love cream? Because the lady can apply it by herself, and it covers the circumference of vagina all around. We know that the vagina has a different thickness in the years when we are reproductive, and it decreases as we age. With the estrogen therapy, we like reverse a little bit of this. So healthcare providers shouldn't be scared about prescribing local estrogen therapy, because they think the ladies will get breast cancer or other gynecological cancers. There is no data, there is no studies showing the connection between the two. Because by local application of the estrogens, you don't alleviate the serum levels of hormones, okay? And you improve the quality of life, not just the urinary incontinence, but we know, for example, if you have a patient with the urinary tract infection, it will heal much faster if you give the local estrogen therapy for urinary tract infection. If we have no change, or we are not satisfied with the result, in some patients, especially the ones with urge or mixed urinary incontinence, we have to deal with the medical therapy. So there are drugs available. I wouldn't bother you, as all the treatments, they have some of them some side effects, but they really work very nicely, and this is something to deal with the healthcare professionals. If we're not satisfied with this, then we have some other treatment option. I believe you have heard about the intravesical application of botulinum toxin. So it's not only given in aesthetic medicine, in dermatology, but it's also one of the treatment options for the patient whose urinary bladder is overactive, because our bladder is a muscle. It's a muscle whole muscle, and if it contracts, the urine leaks. So if you put on the certain points in the urinary bladder Botox, then it doesn't contract that much. So as you have a nice toned face, in that way the urinary bladder acts. Like with application of the Botox in dermatology, which lasts few months, this is the same case with the application of the Botox in the urinary bladder. It has to be reapplied every 6 to 9 months. Also, we can have percutant stimulation of nervus tibialis and sacral neuromodulation. You know about the good effects of functional magnetic stimulation of neuromodulation in an S2, S4 part, but these are special machines, special applicators that are put under the skin, and the roots of the electrodes are put inside very near the endings of the sacral nerves, and in that way they are doing with neuromodulation. And in the end, we have the operative techniques. I named them here sling because majority of them are like strained. They are made from, majority of them made from artificial material. It's polypropylene. And David spoke about the nasty side effects of those slings. So we should be very careful about putting the slings. And about 10-15 years ago, there was a tradition, see one, do one, teach one. So you would go to some kind of course, see some expert putting the sling, you would go back to your hospital and start doing it by the cookbook, by the rules. Fortunately, this was not the case in our countries because we have different kind of training. But in the countries where it was allowed to do so, they had a huge problem. So a lot of slings were put in the patients, they shouldn't be having slings. So then we talked about the quality of life of the patients with urinary incontinence. It's non-existent. Their quality of life is deteriorated in all sorts of ways. The majority of those patients still work, so their productivity is quite low and their absence from work is increasing. The young women can go to the playground with their children or a little bit older with their grandchildren. They, as I told you before, wear clothes that are different, and even the bedding, they put the bedding which is waterproof, so not to get the urine on the bedding. And they lower their social interactions. Those patients don't go to the cinema, don't go to the theater, because they are afraid that in the middle of the film they will have to go out. They don't travel by public transportation except the train, because trains have toilets. By buses, no way. And they plan their way of trip from point A to point B just by availability of the toilets. So my patients told me they go to the supermarkets in great malls, in the big malls, because on every floor they have a few toilets they can go to. So they're afraid that even by doing such elementary chores in their lives, they will have a problem. Of course, it results with, let's say, psychological problems. The guilt, anxiety, they are always anxious that something will happen. And the fear of losing the control of urinary bladder in those patients is very severe. And they are so afraid of that smell of the urine that everybody will see. They are not afraid just of people outside their family. Sometimes those ladies just are afraid of telling their husbands about their problems, so they avoid intimacy and social intercourses because some of them have a urinary incontinence even during the sexual intercourse. So you all know about the mechanism of functional magnetic stimulation. What is very important that is a non-invasive therapy. So, and it's applicable to all types of urinary incontinence. And that is something that we all must remember and come to as information. You all know that electromagnetic field causes deep stimulation of the muscle structure, and that repeated contractions are similar to Kegel exercises. What is also important that if we don't have a direct contact of the skin and the electrodes, so we don't have the pain sensation because the proprioreceptors of the skin are not activated as in electrical stimulation. You know that we have the contractions of the muscle and the strengthening, but what is also very, very important, and I think yesterday you pointed out too, is this. Depolarization also occurs in the sensory afferent fibers of autonomic fibers that regulate local blood flow. The blood vessels also have a little muscle rim around them. So you don't just get the activation of the muscle strength, you also make much more blood flow to the area. And that is something that gives those muscles new strength, new oxygen and glycogen to work with. So it's not just the performance of the muscle, it's also high oxygenation of that area, okay? So it's something that is very important, and we don't have it with the electrostimulation. So they have just muscle contraction, but they don't have the promotion of the vascularization. So I have to say that in Croatia, functional magnetic stimulation is covered by the social security. So everybody who has a social security, and in our country, it is a wonder not to have social security, can have this kind of therapy. So we are fortunate ones. We have a therapeutic cycle twice a week. I have the ladies, one group is Monday, Thursday, the other group is Tuesday, Friday. They come twice a week for 8 weeks, that is 2 months, in total 16 times. So during one calendar year, they can come to one Thursday. Yesterday, you were talking about the treatments that are done in aesthetic medicine. And their patient can come 2 consecutive days. With this, I wouldn't advise because they need a rest period between the stimulations. So we have those 2 groups. I will show you how it looks like in my hospital. 5 years ago, we got the first new chair that had applicators in the seat and in the back side of the chair. And it was a huge success because before that, more than 10 years, we had an old system of functional magnetic stimulation, which was more heating the seat and the pelvic of the patient than during the contractions. And when we started the therapy with this new machine, the ladies that previously went to the old machine said, what is this? This is something completely different. So last year we got another chair because I can humbly say that this kind of therapy is one of the most money receiving treatments in my university hospital center because we have no repro material. So once you buy a chair, that's it. You just spend your money on the electricity, and it's not that bad. So, and for disinfectants to clean the chair. The input of our nurses is very small because every of the patient that comes to the chair, I examine them before. So I write down on my analysis which type of the procedure, so which type of stimulation the lady should have, and at which level she should start. And then our nurses, with each session, alleviates the contractions depending on the feeling of the patient itself. So now we have 2 chairs, and maximum number of patients we can have in 1-2 month tour is around 30 to 35, but maximum is 40 because we have 2 chairs, and they operate from 8 in the morning till 6:30 in the PM. What is very important, we are a public hospital, but they choose the time where they can come. So some of them come during the lunch hours, and we gave them the 30 minutes time. In some stimulation, the time is 25 minutes, but we allow it the 30 minutes so that it can be cleaned and everything. So it's very popular stimulation, and I will tell you how many patients we had on those chairs. I wouldn't bother you with this because you already know everything about it. David told something about the type of urinary incontinence and how it is the mechanism of urinary incontinence. What I would like to say, David was talking about the studies. This is one of the first studies who had results of functional magnetic stimulation for urinary incontinence with 2 groups, one placebo and one done in proper functioning functional magnetic stimulation. It was done by the Professor Booth for the University Center in Maribor, and at that time I was there during my education, and I saw some of those patients, and as David said, they had to be very careful how to divide those patients because the ones that have been on the proper functional magnetic stimulation knew that it doesn't just, rumble, it gets the contractions. So he had results with urodynamical testing, which is very objective, and also the clinical parameters. So they analyzed the frequency of the void. With black color are the patients who receive active therapy, and with red one, the one with the placebo. So the frequency fell from 9 to 6.7. To you, maybe it's 9 times you go to the toilet or 6. It's a big difference. Nocturia, the people in average had 2.6 night voids. It fell down to 1.4. The use of the pad fell from almost 4 to 2. And the pad weight, when you analyze the patient in the office, you give them the pad which you weigh before you give it to the patient. And afterwards you give it to the patient, she put it between her legs, and she does the exercises or the thing that promotes leakage of the urine. After that, you weight that bed again, and you know how much urine this lady leaks. So it's very, very precise. And then they did the urine dynamic testing. And you can see by the numbers that in the active group, they had much better results than in the one that was on placebo and without the therapy. So it's not placebo, it works. So I will tell you about a few things about the fecal incontinence. I am a gynecologist, but our pathologists at the hospitals know about the work that we do, and we're wondering if we can help their patients. So fecal incontinence is debilitating state that is the loss of not only the stool, but also the flatus. So a lot of patients have this problem, and the incidence is thought to be around 11 to 15%, but nobody knows if it's underestimated too due to stigmatization. So I found only one study in the PubMed regarding the urinary incontinence and fecal and functional magnetic stimulation. It was done in 2020 by Italian group. They had 30 patients. What I want to say that these patients had so-called idiopathic fecal incontinence. So no one of these patients had operation due to colorectal cancer or any kind of operative procedure. As you can see from the 30 patients, the average years were around 65, and the majority of the patients, 86%, were females. What is also very important, that 70% of those ladies gave birth to the babies, and just 23% of those ladies had episiotomy. Episiotomy is the incision in the perineum during the last phase of the birth, which allows the head of the baby to easily pass through the perineum. And some say that it's barbaric and that we do crazy things, but it's the way to protect the pelvic floor and to control the way that the devastation of the perineal tissue will arise. So only 23% of those ladies had episiotomy, and you can see that incontinence score fell from 12 to 4.7 after the treatment. But what I would like to say, so those are people with idiopathic urinary incontinence, and see how they were treated. Only 15 minutes once a week for every 8 weeks. For me, this is too little. And even with this, they had great results. So just once a week for 15 minutes, which is twice less than we usually do, and we do it usually twice a week for 8 weeks. So they had very, very good results for suboptimal for me treatment. What we are doing in the University Hospital Center, how we started treating female patients with fecal incontinence with the collaboration of our surgical department, but female patients after surgical treatment of malignancy of the rectum. So those are patients who had operative procedure, who had chemotherapy and radiotherapy as well. We are treating them 30 minutes twice a week for 8 weeks. We started around New Year's Eve, and I hope that next year we will have some results. This is the program I'm using, so we will see how it ends. The first ladies that went to the chair, we had around 15 so far. Some of them are not completely without fecal incontinence, but the amount of fecal incontinence episode has dropped. So they still have fecal incontinence, but not 3 or 4 days, but a lower number. So the improvement in the quality of life is still very satisfying. So I can conclude that today no side effects have been reported in the therapeutic application of this procedure, and it affects and increases the strength and endurance of pelvic floor muscle and sphincter muscles, but also the vascularization. And yesterday I put this because in one of our very popular regional newspaper, there is an article about revolutionary solution for incontinence. I think you all know about this chair, and they write that in Croatia recently we have a therapeutic procedure for effective prevention and treatment of incontinence with the pelvic floor muscle strengthening. And they say that it's an innovative machine with higher safety and precision, and it lasts 30 minutes. People sit with their clothes on, and they say you can watch TV and read newspapers. I agree with everything, and they say that a clinical improvement is around 90%. I agree with everything, just not with the fact that during the therapy the patients can read newspapers or watch TV. I forbid that to my patients because when they're on the chair, I want them to be in the contact with their body so that they feel what's happening, so that when they come home, they can better produce the exercises and that they are in contact. Because if you're sitting and watching TV or reading what's new on the Facebook, the quality of the therapy, in my experience, will be much less. So we have more than 500 patients that have been on this new chair, the Tesla Magnetostim, and we are doing the data with our statistician. So next year you will have our publication for more than 500 patients. So I thank you for the listening to me, and really one of our greatest fear in is